Well, g'day folks, it's Min Lakong here of the Pre-Hospital Retrieval Medicine Podcast. I'm doing another PK SMAC 2013 entry because many of you have put in multiple entries and I thought I couldn't let you guys have all the fun. So I'm going to do a short one on delayed sequence intubation. So you probably know me, but if you don't, that's my blog site, prehospitalmed.com, Pre-Hospital Retrieval Medicine. I have my own opinions, and this is expressly my own opinions. This talk, I am not paid by any drug or equipment manufacturers, and I don't represent my employer, the Royal Flying Doctor Service of Australia, Queensland section. So there's a shot of me in the magazine on the telehealth desk. There's an aircraft there that we fly in, the Super King Air B200. I have research and clinical interests in airway management and procedural sedation in emergency settings and retrieval settings. And I work there where the arrow is, up in Cairns. So, yeah, that's me. So, I attribute this talk to one of my mentors, Dr. Scott Weingart, who has published two articles which are listed here, one in Annals of Emergency Medicine and the first one in the Journal of Emergency Medicine. So they're the references for this slide presentation. So delayed sequence intubation, specifically as taught by Scott, look, it's his own concept that he's brought into the emergency world. In anaesthesia, where I did my training, this is not an unheard of concept in the past. The fact that you may need to give some sedative agents to help facilitate a general anaesthetic procedure. But Scott's really brought it into his own concept, and this is an image from his website where essentially DSI is the use of sedation to allow oxygenation to occur in someone who is fighting normal procedures for oxygenation. So a delirious patient with hypoxia, they get given some ketamine, they dissociate, they get pre-oxygenated adequately, then a paralytic is given and they're intubated. So why is this a big deal? Because many of us are trained in RSI, rapid sequence intubation. This is a nice cartoon by a European anaesthetist on that website that I've listed there, and many of us have been in this situation. You look at the cartoon, someone's trying to intubate, someone's watching the clock. I think someone's even putting cricoid pressure there, and look at the monitor, which is all behind them, which when you think about it, that does happen a lot. A lot of emergency department resus rooms, the vital signs monitor is actually behind the intubator, and who would have ever thought about that until now? So and you see the patient rapidly desaturating. So the game here is get the tube in quickly, and it's a race against hypoxia. So I think that can be a really stupid idea, and I think RSI can be stupid because you forget the basics, you forget positioning, you forget things like having the SATS monitor right in front of you, equipment checks, role allocations, focus on getting a perfect view, obsession with passing the tube, a failure to confirm position early and reliably. And really, one of the greatest sins of airway management is a failure to oxygenate during the procedure, and a failure to go up early and proceed to alternative techniques. So, unless you're a Smurf, blue is not a good colour to be. What do we really want for patient safety during intubation? I think we want a physiologically safe intubation rather than an anatomically successful intubation. No point getting the plastic between the cords if the patient suffers significant hypoxic injury, hypotensive injury, and they could have long-term sequelae as a result. So we want to maintain oxygenation at every step as an absolute priority. Along the way, we want to minimize airway trauma, prevent aspiration, minimize awareness and pain. But you say classically in RSI teaching, pre-oxygenation should achieve this first goal of safety. But we have patients in the emergency setting who don't fit the normal textbook definitions, and they're very hard to pre-oxygenate. And the agitated delirious patient is one of those patients difficult to pre-oxygenate. Dr. Bill Hinckley, one of my colleagues from the Air Medical Physician Association, he wrote this great slide that the pulse oximeter, in fact, is a time machine. It only tells you what's happened in the past. And this is why DSI is more relevant to us, because when the pulse ox is falling, we're already 90 seconds behind the 8 ball, and the patient is already critically hypoxic. So RSI has kind of always relied upon speed, but really DSI focuses on the pre-oxygenation and the maintenance of oxygenation during the intubation procedure. Dr. Rob Bryan, another colleague of mine from Utah, he did this great slide called the oxyhemocoaster, and we know that once you get to a certain pulse oximetry level, it's essentially like jumping off a cliff, as Dr. Levitan has quoted to me in the past before. So you're right, you push the RSI drugs, and you really are shoving that patient off a cliff, and they start to fall precipitously. So how do you maintain that safe oxygenation level? That's what you need DSI for. So just a quick plug about nasal cannula oxygenation, because I think this should be a part of DSI, RSI, any airway attempt now, certainly for laryngoscopy. We know now from the work that Dr. Levitan and Scott Weingart have done to put together all the research articles and evidence, is that this is a robust technique. Certainly this anesthetic paper here shows that nasal oxygenation, apneic diffusion oxygenation, can almost double your safe apneic time, and it can certainly raise your minimum pulse oximetry reading significantly compared to having no nasal oxygenation. Difficult pre-oxygenation can occur not only in kids, but in the patient group that we see, emergency patients. We see patients who are intoxicated, who are critically hypoxic with their pneumonia, and they are difficult to pre-oxygenate because they may not tolerate the normal methods, face mask and so forth. So some concerns about DSI. Many people have said that we don't have ketamine available. Is there an alternative? Strictly speaking, DSI in its current iteration, the main drug to be recommended for sedation is ketamine. It's one of the safest drugs for this. There have been cases where certainly I have used other agents. Certainly in hypertensive patients, you don't really want to push their blood pressure up any higher. So then alternatively, I've used either ketamine with some droperidol to counteract the hypertensive effect, or some fentanyl, but that is not the strict prescription for DSI. So vomiting is also a concern, but in the 1 to 2 milligram per kilogram IV doses of ketamine recommended, it really is a non-event. It's usually at the higher dosing, 4 milligram per kilogram of the intramuscular route, that you would see more vomiting. Now, let's be honest, DSI doesn't have a lot of evidence base. There is a small case series that Scott and colleagues have collected, and that has been presented at a conference. And other work obviously is going to be collected along the way. But for those who have seen the situation that DSI can address, then I think we all intuitively know that this is a safer technique than traditional RSI. So I wonder though, does DSI, delayed sequence intubation, have a bit of an image problem? No one really wants to delay an emergency procedure, so the fact that you're saying you're using a delayed sequence always, I think, puts people a bit off. So I propose that we rename it to make it sound more acceptable to emergency critical care providers. So how about we call it damage control intubation? Doesn't that sound better? We all know the current principles of damage control surgery, damage control resuscitation, where the goal initially is to restore physiology. It's to not get correct anatomical surgical technique. It's not to meticulously get the anatomy back into place, but it's to do what you need to restore to stabilize deteriorating physiology, and to start to restore normal physiology. And so, the analogy is that you got a hypoxic patient. The goal is not to get plastic between the cords. The goal is not an anatomical goal. The goal is actually to reoxygenate, improve their hypoxia, their acidosis, and start to stabilize their abnormal physiology from whatever pathology that they have. So I would say that, yeah, perhaps let's call it damage control intubation, where the hypoxic delirious patient is stopping you from oxygenating them well for the procedure, and so therefore we want to improve their physiology, and the only way to do that is to give a sedative agent to allow that oxygenation to occur. So look, I thank you for your attention, and I've done a couple of DSIs in the last few months, and certainly this case here that I've shown the video laryngoscope image. The only reason why this was a safer procedure was that they were intoxicated after an MVA and they had a low GCS and needed to be intubated, but they were pulling off the mask, pulling off their monitoring. So I gave them some ketamine and droperidol, allowed them to safely oxygenate, and during the procedure the actual suction failed, and there was a lot of fluids and vomitus in the airway, and the only thing that kept the procedure under control was the fact that because of the adequate pre-oxygenation, it still allowed me some time to safely get the tube in and then re-establish good oxygenation with a secure airway. So DSI saved the day on that case, and I'd certainly recommend it to you to at least consider, and perhaps consider how it would be part of your own armamentarium for airway management. So thank you very much.